Great. Yeah, I think I'll spend the next 20 minutes or so just sharing something new that we've been using in the pediatric service, both for planning and for patient education and family education, and that's the use of virtual reality to prepare ourselves and our families for epilepsy surgery for seizures. The best way to illustrate how helpful this has been to my surgical practice and how it's facilitated some of the surgical planning is to just discuss a case that came up a couple years ago now, and take you through how I would normally work them up, and then show you how VR has been changing the game a bit about how we approach it. So this is a 10-year-old girl who is brilliant, super genius girl, A+ student, and just was slowly starting to show a decline in her school performance over time. And her test scores were coming back lower and lower. And this just was not her. Nothing else was going on to explain this decline. And over time, eventually her teachers and then ultimately her pediatrician realized that she was probably having some seizure activity where for 5 minutes or so, she would, up to 5 minutes, she would stop what she was doing and she'd start picking with her right hand. And initially she didn't have the behavioral arrest, and she was just picking. And I think her teachers were just kind of blowing it off as just a behavioral thing that she was doing, but it was becoming more and more and more prominent. And as I mentioned, it started to include behavioral arrest. So she was ultimately diagnosed with seizures. And this was going on, when they kind of thought more back to when this all started, it was going on for a better part of a year. And she was ultimately started on anticonvulsants, and they weren't touching her, and she was getting up to 3 now, and her seizure workup was ongoing. She got an EEG, and it showed that her seizures were coming from her left temporal occipital junction, and then ultimately she got a scan done, and it showed a lesion. So this is one of her images. This is a FLAIR scan showing a left temporal occipital tumor, kind of in the mesial temporal occipital junction here. This is not a contrast enhanced scan, but I can tell you that it was very blandly contrast enhancing, but it's deep, and it's surrounded by pretty normal anatomy. And some of that anatomy included her speech cortex and her optic radiations. So just highlighted where the lesion was. As I mentioned, there's some functional concerns here in thinking about how we can approach this, where I'm worried about where this tumor is sitting deep to her optic radiations, both above and in front. Her speech cortex, which I've kind of cartooned in here, again, lateral and superior. And it's not just her functional anatomy that was kind of concern, it was her venous anatomy. As you know, her vena vallae would be plugging into her transverse sigmoid junction at the base of her skull there, and that's a tethering point. So even if I thought maybe I could be slick about it and slide under her brain and do a subtemporal or even a suboccipital approach, I'm tethered by that temporal occipital junction, that vena vallae, and there's only so much tension I can place on that and run the risk of potentially tearing any of her venous anatomy. So it's an important kind of exercise to go through, because I have to decide, am I going to try and come through this from a supine approach where she's face up, or and come from the front, or do I put her prone and come from behind? And we do prone surgeries all the time, but we don't take that lightly, because our anesthesiologists are now having our patient upside down, and if they were to run into any cardiovascular event during the case, it's not trivial to close the head and bring them back to supine to start CPR. So, again, we do it all the time very safely. It's just that you never take that decision lightly. So this exercise I just took you through of running through all these images, these 2D images that are black and white, by the way, at best grayscale, running through them in different planes, thinking about different functional concerns, thinking about different anatomical concerns, looking at them from different angles. This is an exercise that we do every day as surgeons, where we are trying to synthesize a 3-dimensional model from 2-dimensional images. And as you might imagine, you get better and better at it over time. But although many surgeons don't want to admit it, they're still a human, and they're still subject to errors or just miscalculations, and sometimes millimeters matter. And so this is somewhat of an archaic way to prepare for this very 3-dimensional task of brain surgery, is to use 2-dimensional images. So this is an example now of the same patient who I've taken the two-dimensional images and I've synthesized a three-dimensional model. And as you can see, the first thing that pops out at you is that we're no longer looking at a black and white world anymore. We're no longer looking at a grayscale world. This is painted according to color schemes that I had decided. If I wanted to paint the Venus anatomy kind of a shade of blue or a purple the way it is in real life, I can do that. If I wanted to shade in her optic radiations so that they stand out a bit more, and you can actually see the sweeping of these radiations in three-dimensional space. There's more depth associated with all of this, and these images can be manipulated. So I'm going to just play this movie, and while it's playing, you can see how we have the option of rehearsing these surgical.
Get something like that.
We can come at this tumor from the front, and I think some of the things that are jumping out at you, that there's some vessels on this tumor that really don't really appear very well in two dimensions, and at best you might see them as little dots or oblique little lines, but it's not very obvious where some of those tumor vessels are, but instead they're really jumping out at you. Another thing you notice is that you can gauge how much those optic radiations are sweeping down or coming close to you, and from the front there's kind of sweeping into your path a little bit. And so for that reason, it's potential that we might want to not come from the front, instead kind of sweep behind the transverse sigmoid junction and let those optic radiations sweep up out of our way. And in the meantime, there's a nice wide corridor where no venous anatomy is in the way, and we're coming at this thing. And again, you can see some more some surface vessels that you really didn't see on the 2D. So it's a very different way of looking at this problem in a way that you can actually manipulate, and I can do this on my desktop if I wanted to, but the better way to do it is to actually put on goggles and move these images in the comfort of your office days or even weeks before surgery. I'm just highlighting here some of the things that were popping out on the 3D model that weren't showing up on the 2D. In this case, there was a surface blood vessel that I kind of want to be aware of as I'm coming in. For tumor surgery, if at all possible, you want to sacrifice a lot of these surface blood vessels that are feeding the tumor, but you want to be really careful that you understand the path of these vessels, because if they're just an en passage vessel, just hopping a ride on the surface of this tumor, or maybe even buried inside the tumor on their way to something else, you don't want to sacrifice those, because you could create a stroke distal to where you're operating. So you always have to kind of pick your battles and make sure you know what you're dealing with, but it makes that task much easier when you can see it all in 3D instead of these little two-dimensional blips. So this is just a kind of a comparison of, we had some surface vessels that we had to be on the lookout for, and somewhere in this tumor is buried a vessel that when we followed it in VR, it looked like it actually was traveling through the tumor and heading up to this patient's optic radiations. So in this case, we had one of the first things we saw was this surface blood vessel, which we followed, and it was just feeding the tumor, and we were able to take it. And as a result, the tumor was very avascular by the time we were starting to resect it. And then during the course of the tumor resection, we found this guy who was traveling through the core of the tumor, and as you can see, was just hitching a ride. Every once in a while, it was sending off some branches to feed the tumor, but its real destination wasn't the tumor at all. It was actually heading up into this white matter, and that actually was where the patient's optic radiations were. So this is just an example how we use VR to kind of prep for this tumor, and we did a little bit of electrocorticography and found that a lot of this tissue was seizing. We were well clear of our optic radiations, but she had a gross total resection. Vision was totally intact, and her speech was intact, and she had a complete recovery, seizure-free now for 3 years. So another example of how this kind of mental twister activity is facilitated by VR is with one of the newer ways that we actually monitor and listen to seizures, Stereo-EEG. So for those of you who are not fully aware, instead of doing craniotomies and laying down sheets and strips of electrodes, implanting them, closing up, and then coming back days later. Instead, more and more, what we're doing is making very fine nicks in the scalp, small twist drill holes in the skull, and using stereotactic coordinates, we're floating down depth electrodes. And so because they're very fine twist drill holes in the scalp and the skull, it's much less painful, and the recovery is much quicker. You have to have a really good sense, though, of where you want to listen to. It's kind of like a strategy in picking a fishing hole or a fishing spot. It doesn't make a whole lot of sense to deploy your nets and your lines in a place that doesn't have any fish. You have to spend some time localizing and where you think these seizures are coming from, and having a very solid hypothesis before you actually submerge these depth electrodes. But the beauty of it is that you're accessing much deeper structures. The brain and the lobes are three-dimensional structures. And when we use the older strategies of grids and strips, they're on the surface, and that doesn't always fully represent trajectories and networks in three-dimensional sense. And so having a depth electrode can provide that three-dimensionality to it. It also makes it much more straightforward and easier to simultaneously listen to multiple lobes at the same time, and even for tough cases where we're not even sure if it's coming from right or versus left, bilateral monitoring as well. So you can place these depth electrodes using a frame-based stereotactic technique, or in our case, we use a frameless insertion, a very low risks of hemorrhage and infection. The way that we can avoid a lot of this risk is by studying the patient's angiography well ahead of time, and poring over these images. But that's not an easy task because, as I showed you on some of those prior scans, these are two-dimensional slices that you're kind of having to navigate through, and you're locked into an axial, a coronal, and a sagittal plane. Well, a lot of times when we're submerging these depth electrodes into our trajectories, it's in an oblique trajectory, and that doesn't really adhere to those three cardinal planes. So this is another example of, if only there was a tool that we were able to manipulate these images in a three-dimensional way and really explore the path of these depth electrodes, it would really make this task a lot easier to plan and ultimately have much safer results. So this is an example of a patient who we treated first with using two-dimensional slices and planned using the traditional way. These are all the depth electrodes that we had planned, but this is one single slice of this patient's MRI. As you can see, he had a perinatal infarct, so he has some encephalomalacia here, and our lead suspicion was that his seizure activity was coming from here, but every once in a while the scalp EEG would light up in the front. So now we have an opportunity to listen to multiple lobes at the same time. But this image here shows you part of the problem. Is it gives the impression that all of these electrodes are actually sitting in one plane, and when absolutely they are not. They're in multiple planes, and you have no concept of how high or how low or how forward they are. And so it's nice to have an ability to make a three-dimensional model. Some of the older navigation systems allowed you to actually make these three-dimensional models. And in this case, we actually have this patient's corticospinal tracts, motor tracts involved in the images here, and they're the yellow optic radiations. So we have some functional tissue in there that we can see, that we care about, and we're trying to thread the needle and avoid all those structures. But that's just part of the problem. And the bigger concern I have is potentially skewering some of these very important blood vessels and not really knowing. So this is really helpful. It gives you a better sense of things, but it's still quite a challenge to deliver these things safely using the standard two-dimensional imaging. So this is an example of a patient, same patient who had the electrodes implanted. Instead of having a big incision, we had these little nicks in the skin and used stereotactic coordinates to deliver the electrodes. And this is the final result. But this goes against kind of, all of our inclinations as a surgeon. I feel safest when I can actually see everything going on in my surgery. And in this case, I can't see anything. I have no idea if how close or how far I am from the vessels. I'm trusting the coordinate planning that we did ahead of time, but it's very nerve-wracking to be delivering 8, 10, 12 of these electrodes and not knowing if number 4 may have nicked a vessel and if there's a blood vessel that's causing a hematoma. It's very unsettling, and it goes against our kind of our general surgical principles of being able to see everything. So you really, really, really want to trust your planning, and this is an absolute measure twice, cut once kind of thing. So the more technology we have to feel safer as we're delivering these, the better. So now you have a sense of how we would deliver these using the standard two-dimensional processing. But there was a moment when I was shopping with my nieces, and because I bought them $200 worth of jeans for Christmas, the cashier said, "Congratulations, sir, for spending this much money. Here, take this virtual reality headset to further shop all of our clothing." And I thought, well, if VR goggles are good enough for for retail and for gaming and for many other industries, then absolutely we should be harnessing this technology for something incredibly important like navigating brains and planning surgeries. So this is some footage of me in the office preparing for a surgery using hand controllers, flying through, and I'm virtually the size of a mosquito, flying through this patient's venous and vascular anatomy, finding my safe path to my target. I'm rehearsing my surgical corridors, and I'm choosing between different options and picking the right one. Same case. And so instead of just looking at it in 2D though, this is an example of us making a 3-dimensional model. And now I have the ability to fly in and around all of these trajectories, slowly peeling away the tissue that I'm less interested in and more interested in vessels. And in this case, the red trajectory looks like it might be tagging a vessel right there. And so that might be one that I'd be able to adjust on the fly while I'm flying in VR and swing it just a little bit more forward. But in the meantime, it looks like all the others have neatly danced their way around all these blood vessels and threaded the needle among all these cortical spinal tracts and optic radiations, and much more interactive and confidence-inspiring a rehearsal of a surgery than the traditional 2D preparation. So I was having a great time as a surgeon using this technology to make my surgeries safer. And I work with kids, and there were some unexpected surprises in engaging my patients with this technology. I thought, well, if I'm having a good time with it, and I imagine that a child, who probably plays video games at home and may very well use virtual reality goggles to play those games, might get a kick out of this. So I decided to engage my patients with the goggles, and this is actually one of our very first experiences navigating with one of our patients. So I'm showing her her tumor and showing her my plan. Straight down to it, and actually, and in the middle of it, she reaches up and grabs her tumor. And this is 2 days before her brain surgery. And instead of being completely overcome by fear and anxiety, she was smiling and laughing and giggling. Her parents were behind her, and they were very stressed. And the moment she reached up and reached for her tumor and laughed, it was like a cloud had lifted and the weight off of their shoulders, and it totally changed the whole tenor of the patient engagement. And a light bulb went off that made me realize that this is such a gift for those of us who work with kids, and where the patient-doctor relationship and rapport is sometimes really hard to establish or maintain. This is a little bit of a Trojan horse of sorts, where I'm engaging them with this really fun and interactive platform, and at the same time teaching them why they're having their seizures, and teaching them how is the doctor going to fix the problem. And there is some catharsis to the process of seeing their tumor or seeing their seizure focus and flying through their brain, and then doing the same thing after the surgery is done and after the seizures are gone, and kind of bringing closure to it and saying this thing is gone. It's a way to re-engage or reintroduce the patient back into their own care. It's a way to avoid a bunch of adults just talking to each other over the heads of the most important people in the room, and that's these pediatric patients. So I recognize it for what it is. It's an incredibly powerful communication tool to link up with my patients and their families. So this was an eye-opening, and so I had it generated a series of questions for me. The next question was, how young can we take it? And this is our youngest. He's 4, and he flew around, and I gave him his hand controller, and he could fly around. And a 4-year-old is going to get something very different out of it than a 14-year-old, and that's not the point. The point is that they're not being ignored. They're actually part of this engagement, and they're still benefiting from it. And so I'm actually pretty impressed with how facile even the young ones are with flying around this little pretend world. So next question I had is, well, if I can put the headset on myself and fly around and prepare for surgery, and if I can put the headset on a patient and let them fly themselves around, maybe we can link up all these headsets and link up all of our hand controllers and actually exist in this virtual space together. And maybe we can actually do a virtual tour at the same time. So this is going to be some footage of us doing a shared VR experience where we're flying through this patient's brain. And what you're going to see on the left is we all have these virtual bodies, these digital representations of our bodies called avatars. This is the beta version. It's very bland, and it's the updated version is very gender and ethnically appropriate. And as you can see, everyone has their name floating above their heads, and we're all flying around inside this patient's brain. And then on the right screen is what I can see and what I'm showing the families. But I'm just going to play some footage here and give you a kind of a taste of what this experience is like.
Mom and Dad, see me? We're going all the way inside Jade's brain. Tell me when you get there. And I'm going to turn around. Okay. All right. So if you can actually fly past, hey, Dad, if you can actually fly past me, or get yourselves on either side of me so that I'm not blocking you. But there's something I want to show you. Even more. I'm going to go away a little bit. Okay. And then Dad, can you look over your right shoulder? Like all the way behind you? Keep going. Can you see this arrow that I'm pointing up? All you guys? Yep. So I'm pointing the tumor, but on top of the tumor, there's this blue thing shaped like an S. That's yet another blood vessel that's hiding on the other side of your tumor, meaning it's actually hidden. Meaning if I went through your tumor, Jade, and I kept going, eventually I'm going to hit this guy. That's my stop sign.
So it's kind of like I'm a tour guide, and I've shown them the Mona Lisa, and we were going around and seeing all the great works of art. And at the end of it, they can ask whatever questions they want based on what I've told them. But they also now, for the price of admission, have the ability to just stay in the space and fly around and have some fun. It's just a very, very different way to share the problem and the solution. And it's one that the kids thoroughly enjoy. And after every engagement, I basically prepare a little mini fly through, a little movie of what they just experienced, because only so many people now, especially in the era of COVID, can join in these clinic visits. So, after the session's done, everybody gets an email where they get a fly through of their brain the same way we just did. And in case there's, Uncle Bob or Grandma Joe couldn't make it, now they can share that and share it with their friends. And it just really is an enriching part of the experience. So next question I had was, this is all well and good, and I always have this question is I think I'm pretty clear, and I think my patient's getting it, but I decided to really formally test this question and say, well, I want to see how much my patient's retaining here. So I flew this patient through his AVM. He presented with a seizure, but ultimately he had an AVM. And I flew him through his brain, and I showed him his AVM and taught him a little bit about it. And then I decided to turn it around and quiz him, see how much he actually retained. So this is just some footage of me quizzing him. Able to point to your AVM now? There it is. And then can you point to that vessel that was feeding the AVM? There it is. Oh, you got it. All right, now let's pull that AVM a little bit closer to us, and I want you to kind of rock it left and right and take a good look at it. Look at you. Oh, so good. Actually, and look to your left a little bit. There you go. Now it's right in the center of what we see. Good job, man. You're basically a brain surgeon. So there's a couple of things I want to point out with that. First of all, this patient's not using the hand controls. He's using actually hand gestures to manipulate the images. And this kid actually was a gamer. He actually had used VR before, and he had handsets, but he adapted to this hand gesture thing immediately. And what it made me really fully appreciate is that here I was thinking I'm the technologically savvy adult who is sharing my innovation with this child, and what's very clear is that it's completely the opposite. This pretend world, this virtual world where they momentarily suspend their disbelief and navigate and fly around as if they're a mosquito and manipulate objects, and this is totally their world, and we are actually guests in their world. And I think that basically what it is it's empowerment. I can't imagine, to have this kind of disease process and have adults talking over your head as if you're not even in the room repeatedly, how hopeless and powerless you feel. And I think, to be able to use this platform, which they use readily to play their games and they enjoy, to take back some control and learn, I think is incredibly powerful. But the point of me testing him though was to see how much he retained. And I didn't actually even show all the footage, but he nailed every single question that I had of him in terms of what show me this and point to that. But what I was not anticipating was that I was laser focused on him. He was the subject. He was my patient. He was my test subject. The whole time, it wasn't until I played back this video that I realized, and I hope you heard it in the background, that while he was beginning to answer these questions, in the background was his 6-year-old brother and his mother, who hadn't flown the VR modules, and yet were fighting over each other to answer the questions that I was asking. And so even though I was using this platform to educate my patient, I think it just illustrated how really incredible powerful it was to educate everyone in the room, because it's an interactive and vivid kind of way to really engage. And so I use it now very, very regularly to discuss anatomy and in ways that a flat, bland CT or MRI walkthrough just does not do justice. So I'm gonna go ahead and stop just to make sure that we have time for questions. But those are the main take-home points of how we're using virtual reality now, both for planning purposes and for patient engagement and education. Thank you, guys.